The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Next, let's talk about your endocrine pharmacology, which is a really important topic in pharmacology. We'll start with your hypothalamic and your pituitary hormones. So this is a quick overview. Remember, in pharmacology and in physiology, your hypothalamus will release certain peptides like your thyrotropin-releasing hormone, gonadotropin-releasing hormone, and this will go into your anterior pituitary to tell the cells there to release stimulating hormones. So for example, TRH will trigger your thyrotrophs to release TSH or thyroid stimulating hormone, which then tells your thyroid to release T3 and T4. The same is true with your GnRH or your gonadotropin releasing hormone. This tells your gonadotrophs to release LH and FSH, which then tells your ovaries to release estrogen and progesterone. And the same is true for the other hormones like your somatostatin, your growth hormone releasing hormone, your dopamine, etc., etc. So remember your anterior pituitary hormones, your growth hormone, also known as somatotropin. So again, growth hormone and somatotropin are the same. The hypothalamic hormone that triggers its release is GHRH, and the hypothalamic hormone that inhibits its release is somatostatin. So static, stop. So it stops the release of somatotropin. The target organs are the peripheral organs like your liver, muscle, bone, and kidney. And the hormone or mediator responsible for this is IGF-1 or insulin-like growth factor. And as the name suggests, this hormone promotes growth. Your TSH is released because of the hypothalamic peptide TRH or thyrotropin-releasing hormone. It, of course, targets the thyroid to release thyroxine or T4 and triiodothyronine or T3. You have your ACTH or adrenocorticotropin, which is triggered by CRH from the hypothalamus or corticotropin-releasing hormone. This targets your adrenal cortex to synthesize your glucocorticoids, your mineralocorticoids, and your androgens. We have your FSH and LH, which are triggered by your GnRH. They, of course, target the gonads, your ovaries, and your testes to produce estrogen, progesterone, and testosterone. And naiba si prolactin kasi it is a tonical inhibitor of your dopamine. So, the other way around. Dopamine is the tonical inhibitor of your prolactin. Sorry, nabaliktad. So remember, prolactin is released from the anterior pituitary hormone only if there is no dopamine to suppress its release. And it, of course, attacks or acts on the breast in order to promote milk production. So those are your anterior pituitary hormones. What about your posterior pituitary hormones and the drugs that are mimickers of your posterior pituitary hormones? So one very important posterior pituitary hormone is your oxytocin. Okay, and we also give oxytocin in patients or demoxytocin. Okay, so these are drugs that activate your oxytocin receptors. What do we know about oxytocin? It's really important during labor because it stimulates uterine contraction, and it also stimulates mammary glands to do what we call lactation and milk letdown, which is the release of the milk in order to feed a suckling baby. So again, its uses is in labor induction and labor augmentation. And it is also used in the control of PPH or postpartum hemorrhage because it stimulates uterine contraction, therefore also stopping uterine hemorrhage. Its side effects can be things like fetal distress or placental abruption. It can also cause fluid retention, leading into water intoxication because of hyponatremia, heart failure, seizures, and can sometimes also cause hypotension. Now, whenever we notice fetal distress, or cephalopelvic disproportion or predispositions to uterine rupture, we try to avoid giving oxytocin. So atosiban, okay, so if we have oxytocin agonists, we also have blockers. So atosiban is an oxytocin receptor blocker. However, it is not yet FDA approved since there is a concern about increased rates of infant death. The other hormone that is produced by your posterior pituitary gland is your ADH, or your antidiuretic hormone. So the name of the hormone essentially tells you what it does. So it prevents diuresis. It prevents us from peeing out water by promoting reabsorption of water. So its primary action is on the renal collecting duct to increase water absorption. However, it also has a secondary action, which is why its other name, ADH, is also called vasopressin, because it is a potent vasopressor. So it promotes the constriction of your vessels. In addition to being a potent vasopressor, it also promotes coagulation factor release from the endothelium, particularly your factor VIII. So the agonists for this posterior pituitary hormone, you can give synthetic vasopressin or you can give desmopressin. Now, these two drugs act on different receptors. So we have V1 receptors, which is responsible for smooth muscle contraction in your vessels, which is why synthetic vasopressin would act on V1. Tapos si V2 naman is more prominently found in your renal tubules. So they are important for water reabsorption from the kidneys. And they are also found in the endothelial cells of your blood vessels, which release the factors important in blood coagulation. So let's just show you what V2 or the V2 receptors do. So again, desmopressin is given in these patients. And the reason we give desmopressin is for patients with central diabetes insipidus. Ano nga ulit yung central diabetes insipidus? It could be after, for example, head trauma. The posterior pituitary gland stops releasing antidiuretic hormone. What does that mean? Ihi tayo ng ihi. So the patients keep on peeing out water even if dehydrated na sila, even if hypernatremic na sila. Therefore, they need antidiuretic hormone to pull that water back in. And this is how desmopressin or ADH acts. You have V2 receptors in your collecting tubules of the kidney. And these V2 receptors, when activate, promote the expression of your aquaporins. So aquaporins, they are pores by which water can be reabsorbed from your urine back into your blood. So, okay, AQP is just your aquaporin. They are also used in von Willebrand disease and hemophilia A because they also promote the release of factor VIII. So why will it help in von Willebrand disease if ang kulang sa von Willebrand disease ay von Willebrand factor? Remember that factor VIII helps to stabilize your von Willebrand factor. Therefore, it is helpful in both hemophilia A, which is a deficiency in factor VIII, A for 8, and it is also helpful in VWD. Now, what about antagonists for your ADH? Kailan ba tayo magbibigay ng ADH antagonist? Well, it's when we have syndrome of inappropriate ADH excretion, meaning excrete tayo ng ADH even if we already have enough water in the system. So, of course, if we have a lot of water, we dilute the sodium in our blood, causing hyponatremia, which of course can lead to fluid retention and decompensation of heart failure. So they all end in vaptan, conivaptan, tolvaptan, lixivaptan. So remember, they are antagonists at your V2 receptors. Therefore, they promote water excretion. So they promote na iihi ka, and we use them in syndrome of inappropriate ADH excretion. Now, what is a feared side effect of giving conivaptan? Remember, if you correct hyponatremia too quickly, which is what conivaptan is supposed to do, it can occur or it can present with central pontine myelinolysis, okay, or central pontine demyelination, which is potentially fatal. So that's why whenever we have a hyponatremic patient, we always correct their sodium slowly and we always monitor by how much their sodium is improving. So of these ADH antagonists, ang pinaka-selective sa V2 receptors ay si tolvaptan. Next, we have your growth hormone. Remember your growth hormone, the other name for growth hormone is somatotropin. So we can give the agonists for growth hormone are either somatropin, which is a recombinant growth hormone, or we give recombinant insulin-like growth factor 1 called mecasermin. So both of these will stimulate skeletal muscle growth, amino acid transportation, and cell proliferation. They can be given in patients who have growth hormone deficiency. So the side effects, however, of these two drugs are different. So it makes sense. Growth hormone, go, can cause hyperglycemia, whereas mecasermin, which is an insulin-like growth factor, so diba, insulin-like promotes movement of glucose from the blood into the cell, can cause hypoglycemia. But both of them can also cause intracranial hypertension. Now, for antagonists of growth hormone, why would we want to antagonize growth hormone? Remember in acromegaly, okay, our patients with very coarse facial features, because of a growth hormone excess, we can give growth hormone antagonists. So we can either antagonize growth hormone itself by giving pegvisomant, or we can give an analog for somatostatin. Remember, statin stop your somatotropin. So these are your octreotide and your lanreotide. Again, they are used in acromegaly. And your somatostatin analogs can also be used in the treatment of pituitary adenomas, particularly if they are pituitary growth hormone adenomas. So some side effects of octreotide is biliary sludge and increased propensity to develop gallstones. Next, we have your gonadotropins, useful for ovulation induction, so FSH. We know in females it is important for follicular development. In males, it is important for spermatogenesis. Whereas your luteinizing hormone in females is important for ovarian steroidogenesis to produce estrogen and progesterone. Whereas in males, it is important for androgen or testosterone production. So these drugs are really important in ovulation induction, especially if we want to retrieve and harvest oocytes in patients who are having a difficult time getting pregnant naturally. So the way we do it is we first start by inhibiting endogenous GnRH secretion. So why do we do this? We do this because we want to really control the timing of ovulation and the timing of when we can retrieve the oocyte, fertilize it, and allow embryo transfer. And we do this by giving either continuous GnRH agonism or a GnRH antagonist. So you can give both an agonist and an antagonist, and I'll explain why in a later slide. But we also need to make sure we develop a follicle properly. So we do that by giving FSH injections. And in order to make sure that the follicle matures and we are able to, and we have ovulation, so we can therefore retrieve and fertilize the egg, we need to give LH or HCG. So your FSH analogs are your folitropin alpha, urofolitropin, and menotropin. So they mimic the effects of endogenous FSH, follicle-stimulating hormone. They stimulate the growth of the follicle. So it goes from a secondary follicle to a dominant follicle. And your LH, which if we remember, we need an LH surge in order for ovulation to happen. Your NH analogs like your HCG, they mimic the effects of endogenous LH, which is why if we look at this figure on the right, when we give HCG, we are able to promote ovulation so we can retrieve and fertilize the oocyte. Now, both of these analogs have the side effect of ovarian hyperstimulation syndrome. So from the name itself, it's when we hyperstimulate the ovary, we get ovarian enlargement, ascites, and hypovolemia. So urofolitropin, look at its unique name. It is called urofolitropin because it is actually purified preparation of urine from postmenopausal women. So it contains the FSH that is needed in order to promote follicle stimulation and maturation. Then your LH analogs like your HCG and menotropins, they mimic the effects of endogenous LH. Your menotropins naman is a mixture of both FSH and LH, so they can work in both ways. And your HCG, don't forget, is a LH analog. And I'll explain this part, the GnRH agonist and GnRH antagonist, in a later slide. So let's start with your thyroid hormones. So remember that thyroid hormones are really essential for normal development, especially of your central nervous system, which is why children who have undetected hypothyroidism will develop cretinism. So your thyroid hormones contain iodine, which must be supplied by nutritional intake, which is why iodine deficient patients can have hypothyroidism. So remember that T4 is the main secretory prohormone, meaning ito yung pinakamaraming sinasecrete ng thyroid gland. However, when we ask about which one is the most biologically active, it is your T3 because it has a much higher affinity for the nuclear thyroid receptor compared with T4. Pero kung yung tanong ano yung mas maraming sinasecrete ng thyroid hormone, it's T4. So let's talk about how your thyroid hormones are created and how different drugs block different steps of thyroid hormone creation. So remember that we have the first step, which is uptake and transport. Essentially, when you ingest iodine in the diet, it reaches the blood in the form of your iodide ion, itong I negative. It then enters the thyroid gland via a transporter called your NIS or your sodium ion symport. Okay, so it enters the thyroid gland. Now, this step the uptake of the iodide ion into the thyroid gland is inhibited by certain ions called your thiocyanate and your perchlorate ions. Kasi negatively charged din ang iodide ion, negatively charged si thiocyanate and si perchlorate, they can inhibit the uptake of iodide into the thyroid gland. So these iodide ions are then activated into iodine by your thyroid peroxidase. So nagiging neutral yung kanyang charge. Okay? So TPO, thyroid peroxidase. Again, via the action of thyroid peroxidase, 1 or 2 iodines will undergo what we call organification, whereby they bind to your tyrosine residues within the thyroglobulin. So this is iodination of your tyrosine. If we have 2 iodine molecules bound to tyrosine, we call it diiodotyrosine. So it makes sense, diiodo, dalawang iodine. If we only have 1 iodine bound to it, we call it monoiodotyrosine. Again, makes sense, mono kasi isa lang. So again, through the action of thyroid peroxidase, our favorite enzyme in the thyroid, if we add diiodotyrosine, so 2 plus monoiodotyrosine, 2 plus 1, we get T3. And if we add 2 plus 2, so dalawang diiodotyrosine, we get T4. Remember, your T3 is your triiodothyronine and your T4 is your thyroxine. And that process is called coupling. And lastly, we have proteolysis, where the T4 and the T3 are released from the thyroid and transported into the blood by your thyroxine binding globulin, or your TBG. So it's released into the bloodstream, and then we can recycle this TG or thyroglobulin for further thyroid hormone synthesis. So this act of proteolysis is inhibited by your iodides, and I'll show you this figure here. So again, all the steps and which drugs inhibit which steps. Your transport via your sodium iodide symporter is inhibited by fellow anions, your thiocyanate and your perchlorate. And via the action of thyroid peroxidase, all of their actions are inhibited by your thioamides, your propylthiouracil, your carbimazole, your methimazole. Okay? Iodide itself, so even if it is a very important precursor of your thyroid hormones, they can inhibit both organification and also proteolysis. So remember, proteolysis is the last step where we remove the thyroid hormones from thyroglobulin so it can be excreted into the blood and we can recycle thyroglobulin. So this, iodide, organification, and proteolysis. In addition to that, remember that T4 has to be converted into T3 because T3 is the more biologically active version of your thyroid hormones. And this step can be inhibited by quite a lot of things. So it can be inhibited by your beta blockers, particularly your propranolol. It can be inhibited by corticosteroids. It can be inhibited by amiodarone as well, and even your radiocontrast media, because amiodarone and radiocontrast media both contain high levels of iodine. So you might be wondering, how does iodide or iodine, when ingested, cause either hypo or hyperthyroidism? So your Wolff-Chaikoff effect explains how some ingestion of iodine can cause hypothyroidism. So it might be paradoxical because remember, iodine is important in the production of thyroid hormones. However, if you ingest large amounts of iodine, it causes hypothyroidism via this effect. It is most commonly seen in patients who are baseline already hyperthyroid or patients with Graves' disease. So why does this happen? It's essentially an autoregulatory condition whereby the body rejects large amounts of iodide to prevent oversynthesis of thyroid hormone. So if we look at the figure on the right, via the Wolff-Chaikoff effect, it will block the sodium iodine symport from accepting more iodide ions into the thyroid hormone, again, to prevent oversynthesis of the thyroid hormone. So in patients with a normal thyroid, this is only transient. So the Wolff-Chaikoff effect is transient at the start. And then we have an escape phenomenon where it then starts to ingest iodine and it then starts to accept it into the thyroid gland. However, in patients with autoimmune thyroid conditions like Graves', this escape phenomenon may be absent. So this is why in the movie Chernobyl, remember when they found out about the nuclear meltdown, they started ingesting iodine tablets because this would have caused a Wolff-Chaikoff effect, thereby preventing the uptake of radioactive iodine into our normal thyroid gland. This is in comparison or versus kay Jod-Basedow. Okay, your Jod-Basedow effect is when ingestion of iodine causes hyperthyroidism instead of hypothyroidism. So typically, this only occurs in patients with iodine deficiency. So what happens? Whenever you have iodine deficiency, you tend to be hypothyroid. Therefore, your TSH and your TRH usually mataas kasi you want to upregulate the NIS or the sodium iodine symport in order to allow more and more uptake of your iodine into your thyroid gland. So if you give iodine in somebody who already has upregulated symport activity, you will then get hyperthyroidism. So this can happen not only with ingestion of iodine tablets, but even after an iodine-based IV contrast or amiodarone use. So amioda, so from the name itself, iod, it contains a lot of iodine. So what are some anti-thyroid drugs for patients who are hyperthyroid? So for patients who are hyperthyroid, we have the propylthiouracil and your methimazole and carbimazole. Let's start with your PTU. PTU is where your drug of choice for pregnant hyperthyroid patients, especially during the first trimester of pregnancy. Why is that? During the first trimester of pregnancy, PTU is highly protein bound. Therefore, it doesn't cross the placenta as much. It also has a shorter duration of action and a faster onset of action, which is why we also use it in your thyroid storm, where we need very, very quick, rapid reduction of your thyroid hormones. However, it does have a black box warning of really severe, almost fulminant hepatitis, which is why we reserve this drug only for first trimester pregnancies, thyroid storm, or if they are unable to tolerate methimazole, which is our other drug of choice for non-pregnant patients. So methimazole and carbimazole can cause a granulocytosis. However, they are the drug of choice for non-pregnant hyperthyroid patients because they have one, a longer duration of action and increased potency. However, for pregnant patients, we try to avoid it in the first trimester because they are teratogens. They can cause what we call aplasia cutis congenita, which is misdeveloped skin, especially on the scalp, if we give it in the first trimester. So it also has a slow onset of action. It takes up to 3 to 4 weeks to exhibit the full effect, which is why they don't really inhibit the release of preformed hormones. Kaya kung thyroid storm, kung kailan, very, very severe, you really need to lower the thyroid hormones ASAP or else the patient could die, we give propylthiouracil instead of your methimazole. In addition to being a much quicker onset of action, one other benefit of high-dose propylthiouracil is it also inhibits the conversion of T4 into the more active T3. Kaya especially useful siya in thyroid storm. We also have your radioactive iodine, okay? And this is given when we want to cause permanent hypothyroidism. So, of course, this is contraindicated in pregnant and lactating women because we are essentially giving radioactive levels of iodine. So what it does is it's a pill, you ingest it, and this then emits beta rays to destroy the thyroid. Whenever you give somebody radioactive iodine, you have to supplement their thyroid hormones for life because you have effectively ablated any activity of their thyroid gland. So this can be used, for example, in thyroid cancers. We also can give potassium iodide, KSS, which contains about 50 milligrams of iodine, or Lugol solution, which is also a strong iodine solution. So what it does, or what these medications do, we usually give them preoperatively because they have been shown to reduce the size and the vascularity of the thyroid gland. So this will help when we are about to do a thyroidectomy because it reduces the risk of bleeding, and by reducing the size of the thyroid gland, it also makes it easier to operate on. So remember, just a quick reminder about your thyroid hormones and why they are so important. T4 is converted to T3 in the target cells, and it is T3 that is about 10 times more potent than T4. They are important for your 4Bs, bone maturation, bone growth, beta-adrenergic effects, and your basal metabolic rate. And therefore, patients with hypothyroidism have a very low BMR, meaning they become very, very fatigued. They can often have weight gain even if they're not eating that much. And therefore, we have to give them your thyroid hormones. So levothyroxine, which is what we usually give, that's just synthetic T4. And your liothyronine is a synthetic T3, whereas your liotrix is a 4:1 ratio of T4 is to T3. So it is a mix of both T4 and T3. So which one is our treatment of choice? Again, it is usually levothyroxine due to consistent potency. And it also means, however, because we're giving a T4, we need to also have effective conversion of mechanism. We also need to have effective conversion of T4 into T3 in order for this drug to work. Okay. So let's answer a few questions on the thyroid drugs and the hormone drugs. So Juan is suffering from acromegaly resistant to radiation. You would like to start the patient on an antagonist of growth hormone receptor. Select the appropriate drug. So is it leuprolide, mecosermin, pegvisomant, or decapeptyl? So our answer is pegvisomant. So remember, pegvisomant is a GH analog and is therefore a GH receptor antagonist. So your leuprolide is a GnRH agonist. Mecosermin is an IGF-1 agonist. We use it in GH deficiency, not in your acromegaly. So which drug is not used in the medical treatment of acromegaly? Dopamine agonist, growth hormone receptor antagonist, serotonin agonist, or somatostatin analog? So our answer here is serotonin agonist. Okay, they do not have any effect in the treatment of your acromegaly. Next, let's talk about your corticosteroids. Okay, there. So we will be talking about adrenocortical steroids, your corticosteroids, specifically your glucocorticoids and your mineralocorticoids. We'll talk about things that are agonists, so things that promote their activity, or antagonists, things that block their activity. So remember that most of your corticosteroids are produced in your adrenal gland. Remember, so this is just a review of your physiology of your adrenal gland, starting with cholesterol. We are able to, via a series of enzymatic reactions, we are able to create aldosterone, which is our main mineralocorticoid, and cortisol, which is our main glucocorticoids. So patients with adrenal insufficiency, for example, need supplementation of both mineralocorticoids and glucocorticoids. Why is that? Because both of these mineralocorticoids and glucocorticoids are important in the preservation of your cardiovascular, your immune system, your skeletal muscle syndrome system, and your nervous system. And they also give the body the capacity to resist stressful stimuli, which is why patients who have adrenal insufficiency, meaning they're not making enough cortisol, they're not making enough aldosterone, when they have things like stress, extremes in temperature, or infection, the adrenal insufficiency can get even worse, and this can be fatal, which is why supplementation of mineralocorticoids and glucocorticoids are important in patients with adrenal insufficiency. Do we need to supplement androgens in these patients? Well, not really, if the question is if it will preserve their life, because androgens, okay, androgens are not essential for survival, but your aldosterone and your cortisol are, which is why I'll discuss mostly your mineralocorticoids and glucocorticoids in this chapter. So again, remember, glucocorticoids, from the name itself, it has a lot of carbohydrate metabolism regulating activity, which is why they're called glucocorticoids. In humans, cortisol is the main glucocorticoid and aldosterone is the main mineralocorticoid. Mineralocorticoids have electrolyte balance regulating activity. So how do your glucocorticoids work, or how do they attach to the target receptors? So your glucocorticoid receptors are members of nuclear receptors. So we find the glucocorticoid receptors exhibited by GR in your cytoplasm. When they are complexed with your cortisol, they enter the nucleus, and they can either promote or inactivate gene transcription. So they can either cause transrepression or transactivation. Your mineralocorticoids naman, they are very similar to glucocorticoids in that the receptor is also cytosolic, so it's found within the cell. Once it's complexed with the aldosterone, it then also attaches or goes inside the nucleus and again will promote the synthesis of things like ion channels such as your ENaC or your epithelial sodium channel to allow for things like sodium reabsorption in the kidneys. Now, one thing to note in the picture here, you can see that both cortisol and aldosterone can bind to your mineralocorticoid receptors. Why is that? Cortisol and aldosterone, look at the picture on the lower left, they look very, very similar, okay? And cortisol, so with an L, and mineralocorticoids bind to the mineralocorticoid receptor with equal affinity. However, cortisol is found in the bloodstream at a concentration which is about 1,000 times higher than mineralocorticoids or your aldosterone. So how do we prevent cortisol from constantly activating your mineralocorticoid receptor? Well, we have to deactivate cortisol by converting it into cortisone. And this is done predominantly in the kidneys so that we can prevent cortisol from always activating your tissue-specific mineralocorticoids. Now, what are some of your glucocorticoids? So let's talk about them depending on their whether they are short-acting or long-acting and whether they are low, medium, or high potency. So your lowest potency glucocorticoid is typically your hydrocortisone, whereas the higher potency ones are your clobetasol and your desoxymetasone. So again, what they do is they activate glucocorticoid receptors. Therefore, they have a massive effect on carbohydrate metabolism. So it's thought that glucocorticoids' main function is to protect glucose-dependent tissues like your brain and your heart from starvation. So they will stimulate the liver to form glucose. They will promote protein breakdown and lipolysis to increase substrates available for gluconeogenesis. So they really, really want glucose. So the net result is, of course, an increase in your blood glucose. They also very profoundly affect the immune response of your white blood cells, specifically your lymphocytes. So remember, like I said, they can either activate or inhibit transcription of certain things. So in terms of your glucocorticoids and your immune system, what they do is they decrease the transcription of factors critical for an inflammatory response, like your IL-1, your IL-6, and your TNF-alpha. So therefore, they are very useful in things like contact dermatitis and status asthmaticus, wherein we have an overactive immune system. So it helps reduce some of that immune function. But they, of course, also have the side effect of causing delayed wound healing and predisposition to more infections. So the second major action, so again, we talked about the glucose and the suppresses inflammation. The second major action of corticosteroids on the cardiovascular system is they actually enhance vascular reactivity to other vasoactive substances, which is why if you have hypoadrenalism, like Addison's disease, you are typically unresponsive to things like norepinephrine or angiotensin II, again, because of decreased expression or because of decreased responsivity, vascular reactivity to vasoactive substances. So when would we give these glucocorticoids? So again, you would give them in contact dermatitis, insect bites, status asthmaticus, and of course, in adrenal insufficiency, we have to give both mineralocorticoids and glucocorticoids. Addison's disease, which is chronic adrenal insufficiency. And we give it in thyroid storm because remember, it also decreases the conversion of T4 into the much more active T3. Next, we have your intermediate to long-acting glucocorticoids. They have the same mechanism of action as your short-acting glucocorticoids. I just wanted to point out a few special ones, particularly your betamethasone and dexamethasone. They are used to hasten fetal lung maturation, which is why we give them in mothers who we suspect to have preterm labor so that we can hasten fetal lung maturation. And dexamethasone is used for oxygen-requiring patients in COVID, and via the dexamethasone suppression test is used to test for Cushing's. So we also have glucocorticoid inhibitors, the most important being your metyrapone. So what does metyrapone do? So metyrapone blocks the conversion of 11-deoxycortisol into your active cortisol via inhibiting 11-beta-hydroxylase. So why would we want to inhibit 11-beta-hydroxylase? We use it as a diagnostic test to check kung ang problema ba ay ang adrenal glands or ang ating HPA axis. So what do I mean by this? So we do a metyrapone stimulation test wherein we give metyrapone at midnight, and this blocks 11-beta-hydroxylase. So syempre, we would expect cortisol to be low. So when cortisol is low, we would expect it to tell our pituitary glands to produce more ACTH. And if it produces more ACTH, we should expect na tataas si 11-deoxycortisol. So if we give metyrapone, mababa si cortisol pero mataas si 11-deoxycortisol, we know the HPA axis is okay. Pero if we give metyrapone, mababa na nga si cortisol, mababa pa rin si 11-deoxycortisol, we know that there is something wrong with the HPA axis. Okay, so that is why, or that is how we use the metyrapone stimulation test. What are some other inhibitors of steroidogenesis? So ketoconazole are antifungal. It can inhibit at very high doses 17-alpha hydroxylase. Another anesthetic that can inhibit adrenal function is our etomidate. So if you remember, I mentioned it is good in ITU patients because it is not that depressive for your cardiorespiratory functions, but it can also cause adrenal insufficiency because it can also inhibit 11-beta hydroxylase. Okay. So next, we talk about your mineralocorticoids. So remember, they are really important in promoting sodium reabsorption and potassium excretion. So with sodium reabsorption, we also allow for water reabsorption because where sodium goes, water follows. So the agonists of your mineralocorticoid, so the agonists of your aldosterone are fludrocortisone and deoxycortisone. So fludrocortisone we use in Addison's disease, and we also use it in orthostatic hypotension to promote vascular expansion by reabsorbing sodium and eventually water. So because we reabsorb sodium and water, we would of course have a side effect of salt and fluid retention. And because we're secreting potassium, we would have a side effect of hypokalemia. And because you're reabsorbing water, you can cause congestive heart failure. Ano naman yung mga antagonists at the mineralocorticoid receptor? This is your spironolactone. So we know it as a drug used in heart failure, and it's used as a diuretic, especially if the patient has hypokalemia. Bakit? Because it is a mineralocorticoid receptor blocker, it can cause hyperkalemia because it will prevent the excretion of potassium. Another thing spironolactone does is it has an anti-androgenic effect. Why is that? Because it is also a weak antagonist of your androgen receptor. So you get gynecomastia for patients with or patients on spironolactone. Okay? Next, we move on to your gonadal hormones, particularly your GnRH agonists and your antagonists, which I touched on briefly and I promised I would discuss it. So this is it now. So I don't know why, pero laging lumalabas ang GnRH agonists and antagonists. So it's really important we discuss them now. So let's look at the figure on the left. So to orient ourselves, so this is of course our pituitary gland, and these are our ovaries. Now, in a physiologic state, meaning how the body normally functions, we have a pulsatile secretion of GnRH. Ibig sabihin, hindi siya constant, everyday, same level. It gives GnRH in pulses, right? Pulses, pulses, pulses. And this is what is pro-fertility or physiologic. This is what's normal. Anti-fertility or pharmacologic anti-fertility can happen when you give GnRH agonist daily. So tinatanggal mo yung normal pulsatile fashion of your GnRH and you give it every day. So at first, meron siyang agonist phase kasi you are giving a GnRH agonist after all. But eventually, it will go into the antagonist phase where it will then inhibit the release of your LH and your FSH. So what are the drugs that are GnRH agonists and antagonists? So the way I remember GnRH antagonists ay relix. Relax ka lang. They all end in relix. Ganirelix, cetrorelix, abarelix, degarelix. Okay? So they suppress the LH surge to prevent premature ovulation in assisted fertility. Kasi remember, gusto natin na timed yung ating LH surge. Gusto natin na tayo magde-decide kung kailan tayo mag-harvest ng egg. So we want to suppress the normal LH surge. Therefore, we give a GnRH antagonist. It can also be used in advanced prostate cancer, particularly your degarelix, okay? Because prostate cancer is hormone responsive. Therefore, if we reduce the amount of gonadotropin-releasing hormone effect, we can also reduce the hormones which will respond or which will act on your prostate cancer cells. You have your GnRH agonists naman. So remember, if you give it pulsatile, it is pro-fertility. If you give it continuously, it is anti-fertility. So yung mga agonists mo are the ones that end in relin and your leuprolide. So si gonadorelin, goserelin, nafarelin, triptorelin, these are all GnRH agonists. So they can be used in the palliative therapy of hormone-responsive tumors like your prostate or your breast cancer. And they can also be used to prevent or to help or to diminish the effects of central precocious puberty, whereby masyadong maaga yung puberty sa bata because centrally you are releasing too much GnRH. If you give it in a pulsatile fashion, which is pro-fertility, it would then promote gonadal function. So again, I cannot emphasize this enough. If it's given continuously, it's anti-fertility, ang agonist, even if agonist siya. But if you give it pulsatile, it is pro-fertility or physiologic. So let's answer some sample questions to really hammer that in. Cherry has been receiving fertility treatment. She underwent follicular hyperstimulation for IVF. Identify the drug to be administered to prevent endogenous LH surge that would trigger an untimely ovulation prior to HCG administration. So our answer here is cetrorelix. Remember, relix, relax ka lang, it's an antagonist. Finasteride is a 5-alpha reductase inhibitor, which is used in male pattern baldness and BPH, not in IVF. Menotropin, remember na discuss natin siya kanina, it's one of your recombinant FSH and LH derived from menopausal women's urine. For the treatment of advanced prostate cancer, select the drug that is given to control this condition. So which of these drugs can treat advanced prostate cancer? So our answer here is leuprolide. So leuprolide is a GnRH agonist, but remember, if you give it continuously, it becomes anti-fertility and it becomes useful in the treatment of advanced breast and prostate cancer. Your anastrozole is an aromatase inhibitor. Your cyproterone is an anti-androgen used in hirsutism, and your dutasteride is another 5-alpha reductase inhibitor. So leuprolide is the only one that will actually help with prostate cancer. Anastrozole, is it used for prostate cancer? Remember, aromatase converts your testosterone or your androgen into estrogen. So it's used in breast cancer, not in prostate cancer. Among the following drugs to induce medical menopause, identify the drug that will not cause the flare effect. So lumabas din to. Leuprolide, abarelix, striptorelin, or goserelin. Now, even if you don't know the answer or what the flare effect is, you can do testmanship. Alin dito yung naiba? Relin, and leuprolide. Diba sila ay agonists? Si abarelix, relax ka lang, siya ay antagonist. So even if you don't know what the flare effect is, you know the answer is abarelix. Now, what is the flare effect? Ito yung sinabi kong initial agonist phase when you give a GnRH agonist. When you give it continuously, oo, nagiging antagonist siya, but it first has a flare effect. Okay? And this is only seen in GnRH agonists. So after 1 to 3 weeks, nagkaka-antagonist phase na. Pero, you still have that initial flare effect seen only in your GnRH agonists. So next, let's talk about your estrogen. So, of course, we give estrogen in either, we can give it in combination with progesterone, for example, as a hormonal contraception, or we can also use it as hormonal replacement therapy for patients who are undergoing menopause. It has several effects, and the major estrogen in women is your estradiol. So in the uterus, it promotes proliferation of your endometrium. It also sensitizes the uterus to oxytocin. It is important in your ovary for mitotic effects on granulosa cells. It is important for epithelial growth and differentiation in the breast, for metabolic modulation in the liver, neuroprotection in the central nervous system, and it is anti-resorptive in the bone, which is why postmenopausal women are prone to osteoporosis and fragility fractures because they no longer have the protective effects of estrogen on the bone. Now, what are side effects of giving any drug that contains estrogen? Syempre, there's nausea, there's breast tenderness, again, because they act on breast ductal epithelium growth. And they also have quite a high risk of causing VTE, so things like deep vein thrombosis or pulmonary emboli. Why is that? That is because estrogens can cause a small increase in your coagulation factors, particularly factor 2, 7, 9, 10, and 12. And they decrease antithrombotic proteins like your protein C, protein S, and antithrombin 3. So you are generally in a prothrombotic state. It can also cause migraines, and it increases the risk of breast and endometrial cancer, which can be prevented with endometrial cancer in particular, can be prevented with co-administration of progesterone. Bakit? Kasi estrogen promotes proliferation of your endometrial tissue. And whenever we have hyperproliferation of a cell, there is always that small risk of developing into uncontrolled proliferation, aka cancer. But if we co-administer with progesterone, we mitigate some of these risks. Progesterone naman, the main target is your uterus, your breast, and your brain. Remember, they are responsible for the luteal changes during the menstrual cycle, during the luteal phase. They promote uterine quiescence in pregnancy, so they decrease sensitivity to oxytocin and estrogen versus estrogen that promotes sensitivity to oxytocin. It stimulates alveoli and lobular breast development, whereas kanina, si estrogen, again, was ductal epithelium growth. Ito naman ay lobular growth, and it makes the cervical mucus thick and tenacious. So this usually happens after fertilization of an egg. So you want to prevent another sperm from fertilizing your already fertilized egg. So you get thick and tenacious cervical mucus. So these hormones are better discussed in your OB-GYN module, but I had to go through them as well in pharmacology. So siguro yung pinaka significant or pinaka important in the discussion of pharmacology is your SERMs, or your selective estrogen receptor modulators. Okay, so we have several different SERMs, but what do they do essentially? So what they do is they can either act as an agonist or an antagonist depending on the tissue which they attach to. So for example, if you have an estrogen receptor, they can either cause target gene activation or they can cause target gene repression, depending on the different tissues. So for example, tamoxifen, which is used in the treatment of breast cancer, is good because it antagonizes estrogen receptors in the breast. And we know that estrogen promotes proliferation of breast tissue. So if you have breast cancer, we definitely don't want proliferation of that. However, it is an agonist in the uterus, the liver, and the bone. So we use tamoxifen if the breast cancer is ER positive. So it means it has estrogen receptors. However, because it is an agonist in your uterine tissue, it can cause endometrial hyperplasia, which can eventually lead to cancer. So therefore, we created the raloxifene, which is an antagonist in both breast and uterus so that it doesn't have the same pro-endometrial hyperplasia effects as your tamoxifen. Your fulvestrant naman is a full ER antagonist. So it fully antagonizes your estrogen receptor. And we use this for metastatic breast cancer if it is hormone positive. Lastly, we have your clomiphene citrate, which is another SERM. You may know this because it is a drug used for ovulation induction in women trying to get pregnant. Now, don't be confused kasi according to Katsung, it calls clomiphene a partial estrogen agonist in the pituitary gland. Pero, okay, its mechanism of action is to actually effectively inhibit the action of your stronger estrogens. So again, it's defined as a partial estrogen agonist by your Katsung. Pero how it works is, let me show you let me show you this. So what it does is, so you can see here, clomiphene, it is considered by Katsung as an agonist as your anterior pituitary. But essentially, what happens is, when you have estradiol, which we know is the potent form of estrogen, it causes negative feedback into your anterior pituitary gland. And what clomiphene citrate is it slightly antagonizes estradiol to prevent the negative feedback, therefore promoting an LH surge, therefore promoting ovulation. Okay, so sorry that's a bit confusing, but that's how Katsung defines it. So again, it reduces negative feedback, thereby increasing FSH and LH. And when you increase LH enough to create the LH surge, you get ovulation induction. So the anastrozole, as I mentioned a bit further back in one of the slides, which was one of the choices, dun sa multiple choice question, it reduces estrogen synthesis by inhibiting aromatase. So we have anastrozole, letrozole, and exemestane. Okay. So aromatase, if we remember, is the enzyme that converts testosterone to your estradiol or your estrogen. And it also converts androstenedione to your estrone. Therefore, we give it in breast cancer patients because we want to always reduce the amount of estradiol and estrone in patients who have hormone-responsive breast cancer. So some of its side effects, unfortunately, include things like osteoporosis because we remember that estrogen is bone protective. So if we reduce estrogen, we also reduce the bone protection. We can also get joint pains and musculoskeletal disorders because of it. Because we're also reducing estrogen, parang naging menopausal state tayo, and so therefore, patients can have hot flushes or symptoms of menopause. So we use this whenever there are breast cancers that have become resistant to tamoxifen. And one thing to note, amongst the three, ang pinaka-irreversible sa kanila ay si exemestane. Siya ang irreversible inhibitor. Okay? So again, just to overview of how your hypothalamic, pituitary, and ovarian axis works and the drugs that act on it. So GnRH, it can either be antagonized by a GnRH antagonist, or it can be promoted by pulsatile delivery of your GnRH agonists, or it can be anti-fertility if you give GnRH agonists regularly. Okay? Your anterior pituitary gland, this is where your oral contraceptives act. They act to inhibit the release of FSH and LH, therefore reducing somebody's fertility. Or your clomiphene citrate can act here to prevent the negative feedback of estradiol at your anterior pituitary gland. Your anterior pituitary gland release your FSH and LH, which promote your ovaries to produce progesterone and also to produce estradiol and estrone. But your ovaries don't produce estradiol and estrone kaagad. They actually produce testosterone and androstenedione first. And it is via the action of aromatase that they are converted to your estrogens. So by giving things like anastrozole, letrozole, exemestane, we can inhibit aromatase, and we can therefore reduce the amount of estradiol and estrione that we have. And when it comes to your estrogen receptors, we can give your SERMs, which are your selective estrogen receptor modulators, which can be an agonist or an antagonist, depending on which breast or which tissue it is acting on. Or it can be fulvestrant, which is just a complete antagonist at all estrogen receptors. Okay. Next, we have your androgens, specifically your testosterone. Remember, they are synthesized from your progesterone and your DHEA or your dihydroepiandrosterone. So they are converted by your target organs into your dihydrotestosterone or your DHT, which is the active hormone of testosterone. So we can see here via the action of 5-alpha reductase, we convert testosterone into dihydrotestosterone. So they are responsible for the secondary sexual characteristics of males. They are responsible for fertility and libido of males, but they also cause things like male pattern baldness, enlargement of the prostate gland, and they also cause increased muscle mass, of course. So we have antagonists of androgens, specifically your tamide, your flutamide, bicalutamide, and your nilutamide, which are competitive antagonists at your androgen receptor. So syempre, we would use that for prostate cancer because prostate cancer is androgen receptive. So the side effects, if you're reducing the amount of testosterone you have, you can get things like gynecomastia and impotence. So your GnRH analogs, remember leuprolide, remember we can give them in patients with advanced prostate cancer. Pero di ba yung analog mo, if you give it continuously, you have the flare effect before it becomes antagonist. So therefore, typically, to stop the flare effect, we have to give a antagonist of your androgen receptor. So we can give flutamide at the start to prevent the acute flare-up of prostate cancer during the flare effect when we give agonist therapy. Then we have your cyproterone or your cyproterone acetate, which are antagonists at the androgen receptor. So they suppress the feedback enhancement of your LH and your FSH, which is why cyproterone can be used for women who develop hirsutism, and it is even a component of combined oral contraceptives. So what about inhibitors of androgen synthesis? So ito siguro kanina ang pinakakailangan yung maalala ay ang flutamide. Tapos sa androgen synthesis inhibitors, this is also a very important one. We have your finasteride and your dutasteride. So what they do is they inhibit 5-alpha reductase, which again is the enzyme that converts testosterone into the active DHT. It is used in BPH or benign prostatic hyperplasia and male pattern baldness kasi it's DHT that causes both of these things. They can also be used to counteract the flare effect in GnRH agonist therapy, as I talked about earlier. And the side effects, again, are impotence and gynecomastia because you're reducing the amount of active testosterone. So in the treatment of prostate cancer, leuprolide initially causes increase in testosterone or the flare effect. What drug can be given to avoid this? So as mentioned, it is finasteride. So let's talk about your diabetes drugs. So guys, super duper important on diabetes drugs in the treatment or in answering your PLE, essentially. Lagi siyang lalabas. So before we jump into it, let's remember we have type 1 diabetes and type 2 diabetes. Remember, type 1 diabetes is caused by a autoimmune-induced destruction of the pancreatic cells of the beta cells of your pancreas. Therefore, the beta cells which produce insulin are unable to secrete adequate amounts of insulin. Type 2 naman is more concerned with insulin resistance, especially if you are a patient who eats excessive amounts of food. Therefore, your body keeps secreting insulin. Eventually, your peripheral tissues develop resistance to insulin, and this is the pathophysiology behind type 2 diabetes. So to understand the drugs used in the treatment of diabetes, we have to discuss the ever-important insulin. Remember, it is synthesized as a pro-hormone. Ibig sabihin, when it comes out of your pancreatic cells, it's a pro-insulin. And it is only via cleavage of the C-peptide that we get the active form of insulin. So this cleavage of C-peptide or the levels of C-peptide also help us differentiate whether it is factitious hypoglycemia or real hypoglycemia. Ano ba yung factitious hypoglycemia? So sa mga patients natin with Munchausen syndrome or Munchausen by proxy, sometimes they will inject themselves with insulin to essentially induce hypoglycemia. If somebody is injecting themselves with synthetic insulin, would we expect the C-peptide to be high or to be low? So we would expect it to be low kasi hindi naman kasama ang C-peptide sa synthetic insulin. Pero if somebody really has, for example, an insulinoma and they are actually secreting massive amounts of endogenous insulin, we would also expect C-peptide to be high. Okay? So just a quick reminder of how insulin is secreted. So if this is your pancreatic cell, the beta cell of your pancreas, glucose enters it, okay, and it undergoes glycolysis. And through glycolysis, it is able to produce energy in the form of ATP. And this ATP causes the closure of your ATP-sensitive potassium channel. So what happens when you close your ATP-sensitive potassium channel? Potassium stays in the cell, and therefore you get a lot of positive ions inside the cell, and you get depolarization. And this depolarization causes the opening of your voltage-dependent calcium channels. So this allows calcium to go into the cell. And when there is an influx of calcium, we know that that is usually the preceding step to your secretory vesicles excreting whatever they contain. So in terms of your pancreatic cells, these secretory granules would then secrete your insulin together with your C-peptide. So when it comes to type 1 diabetics, since they do not produce enough insulin or they do not produce insulin at all, we of course have to give synthetic insulin. And we do so in a manner that will mimic as much as possible the normal insulin secretion in a normal human body. So what is normal ba in a human? So essentially, all of us will have a basal level of insulin. Okay, so all of us will have steady, low levels of insulin throughout the day. Even when you're fasting, even if you're not eating, we all have baseline low levels of insulin. Whenever we eat, the insulin levels go up. Because remember, it's triggered by glucose. Okay, so whenever we have breakfast, lunch, and dinner, breakfast, lunch, and supper as per as per your Harrisons, the insulin spikes, okay, in response to the sudden increase in the amount of glucose in our system. So what we try to do in insulin therapy is we just try to mimic that. So we do so by giving a basal bolus insulin, and this is usually achieved by your ultra long-acting insulins, your glargine, your detamir, your lantus, and your degludec. So if you'll notice, wala silang peak and they last for over 24 hours. So if you give them HS or at night, essentially, they last all throughout the next day and they don't peak. They really very well mimic our basal levels of insulin. Pero syempre, kung kakain ng isang diabetic, they then have to give themselves short-acting insulins that peak corresponding to when they eat a meal. So before breakfast, they will give themselves a short-acting insulin analog like your rapid-acting ones, like your Lispro, your Aspart, your glulisine. So they'll give themselves one before breakfast, they'll give them a dose before lunch, they'll give themselves a dose before supper. And this mimics normal insulin release. Alternatively, kasi medyo mahal yung degludec, etc., sometimes this second regimen is used. So what is the second regimen? Essentially, yung basal bolus mo, instead of using an ultra-long-acting one, you can use NPH, which is an intermediate-acting insulin. So versus the second regimen, where instead of giving the ultra-long-acting the night before, we can instead give your NPH insulin. Okay, so your NPH insulin does have a peak at about 8 to 12 hours, pero the duration is also still quite long at 18 to 24 hours. So dahil may peak siya, so you can see meron may peak siya, we no longer give your meal insulins 3 times a day. We only give it twice a day kasi meron ka ng peak at around lunchtime, as you can see here. So you would still give your rapid-acting insulins here before breakfast and before supper, or you can give your regular insulin, which is considered short-acting. So if merong rapid-acting, merong short-acting, intermediate-acting, long-acting, and ultra-long-acting. Ang lumabas sa boards, degludec, ultra-long-acting. Now, what if a patient is type 2 diabetic? Remember, in type 2 diabetes, the mechanism behind the disease is insulin resistance. So it doesn't make sense to give more and more insulin. We have several non-insulin anti-diabetic agents, and the easiest way to study them is to divide them based on their class. So I made up 3 classes to help you remember them. First, we have sensitizers. So as the name suggests, they increase the sensitivity of peripheral tissues towards insulin, okay? You have your secretagogues, which as the name suggests, promote insulin secretion. And you have your incretin-based drugs, okay? Which are, I'll explain a bit later. So your sensitizers are your biguanides, like your metformin, and your or TZDs, thiazolidinediones, like your rosiglitazone. So what biguanides do is they decrease hepatic gluconeogenesis in addition to promoting insulin sensitivity, but they do have quite significant toxicities in terms of GI disturbances. A lot of patients on metformin will initially present with some nausea, which is a very, very common side effect. Unfortunately, they can also cause lactic acidosis, especially in patients who are predisposed to it, such as if they have hepatic or renal impairment. Your TZDs naman bind to your PPAR gamma, which are important for increasing your sensitivity to insulin. Unfortunately, a side effect that has caused this drug to fall out of favor is quite severe fluid retention. So in patients who have heart failure, this can worsen their heart failure. Your secretagogues naman, they can be your SUs or your sulfonylureas or your meglitinides or your repaglinide. So because they increase insulin secretion, it is very expected na yung toxicity nila ay hypoglycemia because they promote insulin secretion independent of glucose. So kahit na mababa yung glucose mo, if you take a sulfonylurea or a meglitinide, you will secrete insulin, and therefore, if your baseline glucose is low, you can develop hypoglycemia. We also have your incretin-based drugs, which I'll discuss in a bit later. So let's start by talking about your secretagogues. So again, they promote secretion of insulin, and they do so via closing your potassium channels. So this again causes depolarization of the cells, and it triggers your insulin release. However, because it acts on the functioning beta cells of your pancreas, it will not work if you no longer have any functioning beta cells. You have to have a pancreas that's still working in order for these drugs to take effect. So your secretagogues are your GLPs, your glipizide, gliclazide, glimepiride, glyburide. So they all sound very similar. So like I said, hypoglycemia is a common side effect. They also cause cholestatic jaundice, particularly your glibenclamide. So these drugs have really fallen out of favor. It's very rare that you will see these sulfonylureas in use because, again, they do increase the risk of hypoglycemia. Then we have your megliptinide, repaglinide, which is also a secretagogue. But the thing about this is it has a very, very short drug duration of action. So typically, patients will take this QDS or 4 times a day, and they only do so after eating. So it's used for postprandial hyperglycemia. Okay. Next, we have your sensitizers or your biguanides. Oh, sorry. First, we have your sensitizers or your biguanides, which are really the most important drugs when it comes to the treatment of type 2 diabetes. If there's only one drug you remember from this lecture, it should be your biguanides. And the most important one is metformin. It is first line in the treatment of type 2 diabetes. It has even been used in diabetes prevention and in patients with PCOS. So sa PCOS, parang medyo cycle siya. So PCOS can cause insulin resistance, and insulin resistance has also been found to increase the risk of PCOS. And so because insulin resistance is so central to the pathogenesis of your PCOS, metformin has been found to be helpful in these patients. So again, it increases your sensitivity to insulin, the peripheral tissue sensitivity to insulin, and it also decreases hepatic gluconeogenesis. Okay. Now, the most common side effect of your metformin is your GI disturbances, particularly your diarrhea. It can also cause some nausea and vomiting. One of the ways to circumvent these side effects is to give moderate release form of metformin. So mas slow yung release ng metformin. This has been found to be a bit helpful in patients who complain of GI side effects. The worst but very rare side effect of metformin is lactic acidosis. Typically, the patients who develop lactic acidosis from metformin ingestion are those who are already hepatically or renally impaired, or if they have something that already puts them at risk of metabolic acidosis in the first place. So things like sepsis, infections, etc. They have also been found to cause vitamin B12 malabsorption. But one good thing about metformin is it does not cause hypoglycemia. It merely increases the sensitivity of your peripheral tissues to insulin. Another sensitizer is your TZD ending in glitazone, pioglitazone, rosiglitazone, troglitazone. So what they do is they increase sensitivity to insulin by activating your PPAR gamma receptor. So don't be too stressed. You just need to know that PPAR gamma regulates expression of genes involved in insulin sensitivity. So that's all you need to know. They also, same as metformin, to some effect, they also inhibit hepatic gluconeogenesis. But the same way that all that glitters is not gold, These TZDs have quite a lot of side effects that have caused them to fall out of favor in modern use. So they cause fluid retention, weight gain, and therefore they can cause congestive heart failure. They have also been found to increase the risk of bone fractures, especially in women. They can also cause dyslipidemia. Rosiglitazone was even pulled out of the market due to the increased risk of cardiovascular events like myocardial infarction. So they are contraindicated in patients with chronic liver disease and congestive heart failure. Pioglitazone has also been found to have a theoretical increased risk of bladder cancer. Now, the evidence here is a bit dodgy, but theoretically, it's supposed to increase the risk now of bladder cancer. Next, we have amylin analogs, so pramlintide. Okay, so what is amylin ba? So amylin is a polypeptide. It is stored in the granules found in your pancreatic cells, and they are released together with your insulin and your C-peptide. So what does amylin do? It reduces postprandial glucagon. So remember, glucagon causes spikes in your glucose. It slows gastric emptying. It activates glycolysis, and it reduces your appetite. And another special thing about pramlintide, which is an amylin analog, is it can also be used in type 1 diabetic. So, okay, remember these mechanisms of action of your pramlintide. They reduce postprandial glucagon, slow gastric emptying, activate glycolysis, and reduce your appetite. Next, we have your incretin modulator. So first, let's discuss ano nga ba si incretin. So incretin is a hormone that is released after an oral glucose load. So if you give glucose IV, it won't really increase your incretins as much as oral glucose will. So what does incretin do? What incretin does is it stimulates insulin secretion. So the best known incretin is your GLP-1 or your glucagon-like peptide 1. And because it promotes insulin secretion after an oral load of glucose, it reduces post-meal glucose excursions. Kasi a lot of your diabetics will have postprandial hyperglycemia. So incretin modulators are very good for those. And so the drugs used as incretin modulators are either analogs of GLP-1, meaning they mimic the effects of GLP-1, or they're inhibitors of DPP-4. So what is DPP-4? It is an enzyme that degrades your GLP-1. So if you inhibit DPP-4, you allow GLP-1 to stay in your system for a longer amount of time. So what are your GLP-1 agonists? These are your tides, exenatide, liraglutide, semaglutide. Semaglutide you would know as Ozempic. It is the drug that is now the celebrity favorite drug because it causes such severe appetite suppression that it is a great weight loss drug. People have lost lots and lots of weight from Ozempic. However, one of the side effects of these GLP-1 agonists is your acute pancreatitis. It also causes nausea and vomiting kasi it delays gastric emptying, so you stay full for much longer. Whenever you eat anything, parang nasusuka ka kasi busog ka pa. It also therefore causes anorexia, you don't eat, and weight loss, which is a side effect that is desired in obese diabetic patients. So hindi pa siya oral, it is administered subcutaneously as a long-acting injectable. And however, liraglutide has been associated with a theoretical increased risk of thyroid carcinoma. So si pioglitazone, bladder, si liraglutide is thyroid carcinoma. Your DPP-4 inhibitors, again, they inhibit DPP-4, so they allow GLP-1 to stay in your system for longer. These are your gliptins. So I remember them as they lift up your GLP-1s. They lift up your GLP-1 because they inhibit DPP-4. So some of the side effects are nasopharyngitis and upper respiratory tract infection. Nasopharyngitis na siguro yung pinaka-high yield na side effect to remember from your DPP-4 inhibitors. It's sometimes administered orally as monotherapy or in combination with metformin, particularly your metformin-sitagliptin combinations. Very common yan na binibigay. So we've discussed your secretagogues, we've discussed your sensitizers, we've discussed your incretin modulators. Now let's discuss the drugs that allow you to excrete more glucose from your system. So you can either excrete them through your poo, such as through the alpha-glucosidase inhibitor, or you excrete them in your urine, like with your SGLT2Is, okay? So what do the alpha-glucosidase inhibitors do? What they do is in the intestine, they inhibit alpha-glucosidase, your intestinal alpha-glucosidase, which is important in the conversion of your polysaccharides into absorbable monosaccharides like glucose. So therefore, if hindi siya ma-degrade into monosaccharides, hindi mo ma-absorb ang glucose. Therefore, you reduce postprandial hyperglycemia. Pero dahil marami kang remaining na undigested and unabsorbed carbohydrates in your gut, your bacteria, your gut bacteria will happily feast on these and you will get gastrointestinal disturbance. Flatulence is very common because these gas-forming bacteria in your gut, while they're eating all that undigested carbs, will make lots and lots of gas. So you get very farty, flatulence, you get diarrhea, and you get abdominal pain. So kung ayaw mo siyang i-excrete through your poo, you can also excrete it through your urine via the action of your SGLT2I or your sodium glucose cotransporter 2 inhibitor. What is SGLT2? It is found in your kidneys, okay? It reabsorbs both glucose and sodium. Therefore, if you inhibit this, okay, you don't reabsorb glucose, instead you pee it all out. Glucose and sodium will then pull water out as well, so you also excrete a lot more water. So it inhibits reabsorption of glucose and it causes excretion of glucose out in the urine. As expected, dahil madami kang glucose in your urinary tract, it can increase the risk of your urinary tract infection, and especially in diabetics, it can increase the risk of what we call your Fournier's gangrene. Kung gusto niyo ng pampagising, you can Google what Fournier's gangrene looks like, but it is essentially necrosis and gangrene of your perineal and genital area. It can also cause weakness, some strong smell of urine, nausea, and vomiting. But I guess what I really want to emphasize about SGLT2Is is it is now touted as one of the miracle drugs in treating heart failure. So I know it says here do not use among renally impaired patients. This is only if they have a very, very, very low GFR. The reason being SGLT2Is have been found to have a benefit in CKD and heart failure patients, particularly your HFpEF patients. Your heart failure with preserved ejection fracture patients, SGLT2Is is now considered one of the mainstays of treatment. And they found that even in patients who are not diabetic, if they have heart failure, SGLT2Is have been found to be beneficial. So your empagliflozin, dapagliflozin, canagliflozin. The way I remember it is flozin. Flozinate your urine, flow the urine, make the urine flow. Canagliflozin, dapagliflozin, empagliflozin. So let's answer some questions so that you really hammer the topics in. So Gabby has been diagnosed with diabetes type 2. She is prescribed with glibenclamide, but still with uncontrolled sugar. The doctor would like to add a second drug. The doctor can choose any of the following except metformin, acarbose, glipizide, or pioglitazone. Our answer here is glipizide. In general, we don't give two drugs with the same mechanism of action, particularly if it's your sulfonylureas, your secretagogues. Why? What is the most common side effect of these drugs? Profound hypoglycemia. Remember, it causes glucose-independent release of insulin. Kahit na konti lang yung glucose ko, wag niyo akong patayin by giving 2 sulfonylureas because I will get really profound hypoglycemia. Which of the following drugs inhibits the reabsorption of glucose in the kidney? So which of the following will inhibit your SGLT2? So diba, make the urine flow, dapagliflozin. Pramlintide or your amylin analog has the following effects except, does it promote satiety? Does it slow down gastric emptying? Does it inhibit inappropriate secretion of glucagon? Or does it sensitize insulin receptors? So the answer is it does all A, B, and C. It does not do letter D. It is not a sensitizer. Those are your biguanides like your metformin, okay, and your TZDs. So that's it for your diabetic drugs. Last topic to discuss in your endocrine pharmacology is your bone and your mineral homeostasis, or the drugs used to maintain bone and mineral homeostasis. So to discuss bone and mineral homeostasis drugs, we first have to take a deep dive into your calcium, your vitamin D, and your parathyroid hormone. So all of these three things are the three key players in the regulation of bone and mineral metabolism. So your vitamin D and your parathyroid hormone work together in a feedback loop to maintain appropriate levels of calcium and phosphorus in the body. So when the level of calcium in the blood is low, the parathyroid hormone secretes parathyroid hormone. The parathyroid gland secretes parathyroid hormone. Now, parathyroid hormone acts on the bone to promote the release of calcium from the bone via reabsorption. So it promotes the release of both calcium and phosphorus from the bone to increase the levels of calcium in the blood. Another thing that parathyroid hormone does is it activates or it promotes the activation of your inactive vitamin D into active vitamin D via the action of your 1-alpha hydroxylase. So it converts 25 dihydroxy vitamin D 25-hydroxyvitamin D to 125-dihydroxyvitamin D, which is the active form. And this vitamin D, this active vitamin D, then acts on the gut to promote reabsorption of both calcium and phosphorus. And in some ways, it also promotes bone formation because it's vitamin D. It increases the availability of calcium and phosphorus in the blood, and therefore you can make more bone. Pero generally, okay, what I want you to focus on is on the last part. The net effect on serum levels is parathyroid hormone will increase serum calcium and decrease serum phos. The reason it decreases serum phos is at the kidney, it causes decreased calcium excretion at the expense of increasing your phosphate excretion. And in terms of the bone, what is its effect on the bone? So kanina, I said it was a resorptive agent, pero it depends on how you give it. So if you give it continuously at high concentrations, you do get resorption of bone, pero if you give it at low intermittent doses, you actually get increased bone formation. Nevertheless, the net effect that you guys need to know is increased calcium and decreased phos. Active vitamin D mostly acts on the intestine to promote both calcium and phosphate reabsorption. Yun yung pinaka-important mechanism ng vitamin D talaga. And so, its net effect is an increase in both calcium and phos. Okay? So, si PTH, increased calcium, decreased phos. Si active vitamin D, increased calcium and increased phos, mostly via increased calcium and phos absorption. So what does recombinant parathyroid hormone do? So your recombinant parathyroid hormone, parathyroid, is teriparatide. So what it does is the same as what the parathyroid hormone does. It inhibits calcium excretion in the kidneys, but it does promote phosphate excretion, and it stimulates vitamin D production and activation via activating your 1-alpha hydroxylase in the kidneys. Now, similarly to parathyroid hormone, at high doses, it increases bone reabsorption. So it does so via osteoclasts. At low intermittent doses, it produces a net increase in bone formation. So, Doc, how does parathyroid hormone or teriparatide do both? So to do that, let's talk about what parathyroid hormone does on a cellular level. So when you have low calcium, it triggers your parathyroid hormones or your parathyroid glands to release parathyroid hormone. So actually, your osteoclast, wala siyang receptor for parathyroid hormone. It's only your osteoblast that has a receptor for parathyroid hormone. So PTH then goes to your osteoblast. So if you give it at low intermittent doses, it has a net pro-osteoblastic effect. And what do our osteoblasts bone? They build bone. Okay, osteoblasts build bone. However, if you keep giving PTH or if you keep giving teriparatide, osteoblast keeps getting activated. And osteoblasts will eventually express what we call rank L or rank ligand. And rank ligand then acts on your osteoclast precursor via the rank receptor. And your osteoclast precursor is turned into an active osteoclast or a mature osteoclast, which, if we know, eats bone. Well, when osteoblasts build bone, osteoclasts eat bone. So they cause reabsorption of bone, therefore increasing your calcium and your phos levels in the blood. So it is because of this effect that high doses causes bone resorption, but low intermittent doses promote bone formation. So teriparatide is the only anabolic agent available that increases new bone formation. Again, only if it's given at low intermittent doses. Now, one thing to note about this drug is that we have to limit its use to less than or equal to 2 years because it increases your risk of osteosarcoma. Next, we have your vitamin D derivatives. You can either give an inactive form like your ergocalciferol or your cholecalciferol, or an active form like your calcitriol, doxorcalciferol, etc. So, syempre, in patients with CKD, but typically they will have anemia. Typically they will have reduced activity of your 1-alpha hydroxylase because, again, you have CKD. Therefore, the preferred form of calcium or vitamin D that we give these patients is your calcitriol kasi it's already the activated form. Furthermore, calcipotriene, okay, which is one of your activated versions of vitamin D, is used in the treatment of psoriasis. So I have prescribed this to patients with psoriasis. It's like an ointment that they apply on the patches, and it has been very, very effective. And it is because it has been found to have anti-inflammatory properties and is actually being investigated for the treatment of certain malignancies and other inflammatory disorders. So the vitamin D derivatives, they cause less hypercalcemia and hypercalciuria compared to your recombinant parathyroid hormone. Okay, so your calcium mimetics, from the name itself, they mimic the effect of calcium or hypercalcemia. So to understand how these drugs work, let's look at calcitonin. What does calcitonin do? So calcitonin is a hormone secreted by your parafollicular C cells in the thyroid gland, and it is secreted when you have a lot of calcium in your blood. From the name itself, calcitonin, this hormone tells you to tone down the calcium. It causes a decrease in serum calcium and phosphate. And it does so by inhibiting bone resorption and inhibiting renal excretion of these materials. So the main effect that we want to get from this drug is by the inhibition of bone resorption. Okay? So what is the calcium mimetic? It is cinacalcet. So essentially kasi PTH is the only hormone, okay? It is the only hormone that is inhibited by an increase in calcium. Diba, most of the other hormones we know, kapag there's an influx of calcium intracellularly, it triggers the release of vesicles into the synapses, and this causes the increased release of hormones. Si PTH lang yung na-deactivate or na-inhibit whenever there is a high calcium level. So cinacalcet, because it mimics calcium, it activates the calcium sensing receptor, therefore it inhibits PTH secretion. And we want this because remember, PTH causes bone resorption. So we want cinacalcet because it inhibits bone resorption, and it can also be used in the treatment of hyperparathyroidism. So it can be used in hyper-PTH, in Paget's disease of the bone, in osteoporosis, and in hypercalcemia. Kasi hyper-PTH causes too much calcium in the blood. So we want to tone it down. We also have non-hormonal regulators. So these are your bisphosphonates, your dronates, alendronate, pamidronate, risedronate, zoledronic acid, etidronate. So they suppress osteoclastic activity. So that's all you need to know. You don't need to memorize farnesyl pyrophosphate synthesis. You just need to know they suppress osteoclastic activity. Osteoblasts build bone, osteoclasts eat bone. So by suppressing the eaters of the bone, you have stronger bones. So syempre, we use it in osteoporosis. So this is the most common use of your bisphosphonates. However, a lot of these drugs, when taken in the oral pill form, can cause esophagitis or pill esophagitis. So typically, we ask patients to be sat as upright as possible, and they have to drink a full glass of water when they take this tablet because it can cause quite erosive pill esophagitis. It can also have osteonecrosis of the jaw as one of its side effects. Another drug used in bone and calcium homeostasis is what we call anti-rankle mab. So remember na pag-usapan ko yung rank ligand, which is expressed by your osteoblast in response to parathyroid hormone, and this causes activation of your osteoclast precursor into active osteoclasts. So what it does, what denosumab does, is it binds to rank L and it prevents it from stimulating osteoclast differentiation. So what it does is it stops this step. So it binds to rank L, denosumab, mab, another monoclonal antibody. So again, it is used in osteoporosis. However, one of the side effects is it has been found to increase the risk of infection. So let's do a few quick questions. Your friend Tim has severe GORD and Barrett's esophagus. However, he also has quite severe osteoporosis. What bisphosphonate can you safely give him? So diba, bisphosphonates can cause really bad pill esophagitis. However, we can give bisphosphonates IV, and the bisphosphonate we can give IV is your zoledronate, thereby bypassing the side effect of pill esophagitis. Which of the following is false about teriparatide? Teriparatide, if you recall, is your recombinant parathyroid hormone. Does it activate osteoblasts? Is it an anabolic agent promoting bone formation? Is it an analog of calcitonin? Or can it speed fracture healing? Remember, it activates osteoblasts if you give it in low doses intermittently. And yes, it does promote bone formation and can therefore speed fracture healing, but it is not an analog of calcitonin. It is a parathyroid hormone analog. The analog of calcitonin is your cinacalcet, not your teriparatide.